Khalessi.
Well, thanks so much for the invitation. I really want our time together to be as high yield for you as possible, obviously. I'm sorry, first of all, I'm down in the same faces, so I just thought I'd dash out and come visit with you guys. I'll just introduce myself and talk to you a little bit about my background, and then the rest of the time is essentially yours, and we can use it however you want. I am a neurosurgeon by training. What that means is I do open cranial surgery in the brain for brain tumors and for problems with the blood vessels of the brain. I also use catheters to treat problems with the blood vessels of the neck and the brain. I direct the neurovascular program at UC San Diego now. I'm an assistant professor of surgery and neurosciences there. And I also am the surgeon director of the neurocritical care unit, so people who are in the ICU who have very bad problems with their brain and spinal cord. I'm responsible for those problems. Armand was kind of enthusiastic about my background, so I'll take a little bit of time to talk through that, because that may be of some value to you as also. I grew up in Orange County, went to El Toro High School, and then went to Stanford College, did a master's there. And then went to Johns Hopkins for medical school before returning to Los Angeles for my residency training in neurosurgery. To become a neurosurgeon, it's 15 years overall, so it's a little while. It's 4 years of college, 4 years of med school, and then 7 years of residency. I direct the residency program at UCSD now, so I'm responsible for training medical students, residents, and fellows now. And this is a presentation that basically walks you through an example of some of the problems that I take care of. We can spend our time together going over cases. I'm happy to show you surgical videos, because when I was at your stage of life, I had never seen what surgery in the brain really looks like. I can show you what that looks like if you want, or I'm happy for this to be kind of an informal conversation, and I can answer whatever questions you want about medicine more broadly, about college applications, whatever you want. What do you guys think? You want to do any? I understand we have. When do we have to stop here? 2 o'clock. Is that right?
1:45.
1:45. Okay, so that basically gives us 15 minutes, right? Am I seeing that right?
Looks like it. Yeah.
Okay, so that's pretty tight. So how about what do you guys want to do?
Aneurysms. I think that's why we're all here.
Okay, so you want to see some of these?
Yeah, the videos would be fine. Maybe just like 2 or 3 minutes at the end to ask a few questions.
Sure. Okay, that's really helpful. So I think what's really important, and one of the reasons I chose to become an academic surgeon is because I think that a lot of people take the advancements that we enjoy in medicine somewhat for granted, and they think that this kind of magically happens. And the truth is, it really takes sustained attention to your craft and sustained commitment to things like research. And so what the early part of this presentation does is it essentially walks through for you a problem 30 years ago that essentially had no solution. So if you have a weakening of one of the arteries of the brain, that's called an aneurysm. And if that aneurysm bleeds, about a third of people pass away, a third are permanently disabled, and a third with maximal medical care will make a full recovery. So 30 years ago, a guy named Charlie Drake up in London, Ontario, had a patient who had this aneurysm. This is a drawing by Drake of the basilar artery and what this giant aneurysm looked like. And 30 years later, this patient actually came in with these images showing what his aneurysm looked like. 30 years ago, this was a death sentence, and the only way to treat that aneurysm was to do a very difficult operation deep in the brain to try to put a clip on the most important brain artery in the body, the basilar artery, which connects the brain to the body, essentially, provides blood flow to the brainstem. And about half of the people survived that. Now, when you have that same case come in, this is someone who came in to UCSD not long ago, we can use catheters and fill that aneurysm with coils so blood can't flow into the aneurysm anymore. And you can actually provide blood flow to the brain itself, but no blood flow into the aneurysm. And in doing that, you can actually protect that patient from having a fatal hemorrhage. Similarly, small aneurysms off tiny arteries, there used to be no surgical way to get to this. It's now quite straightforward to go in with catheters and actually fill that aneurysm up with coils so blood can no longer flow into that. These are very large aneurysms that actually can provide mass effects, so they can blind patients if they're actually pushing on the nerves that are responsible for the eye. They can actually lead to double vision because the eyes won't move properly together, or they can compromise blood flow to the whole left side of the brain if not treated correctly. And so we now have small stents that we can use to fill that aneurysm with coils and protect the artery from bleeding, but also providing blood flow to the entire left side of the brain. So this is just an angiogram. This is me injecting dye through a catheter to show that blood's getting everywhere that it needs to go, but it's not providing any flow to that aneurysm anymore. This is an example of, I'll just move quickly since we have such little time, a woman who basically had a massive aneurysm in her head that other doctors had tried to fill with coils, and it was essentially like a tennis ball that was growing in her head, and it was serially blinding her. And so I actually used a brand new device, which is essentially like a slinky, called a pipeline device that only a handful of people in the country use. This is me putting the device in, and after the device is in, what you see is this dye is just hanging out of the aneurysm. And so that aneurysm is going to clot off over time and heal. And this woman had, I don't know how well you guys know your optometry, but she basically was legally blind. She was 2400 in one eye and what's called LP, or light perception, in the other eye. And after this procedure, she was essentially 20/30 in both eyes. So that pulsatile insult, that tennis ball just pushing into her optic nerves, was fixed by this procedure. And this is just showing you all the dye is gone, but there's just dye hanging out in this aneurysm because the blood's now trapped in that aneurysm and will seal over time. So what I'm going to do here is I can show you this video because I think this will kind of drive home. I can hit it. This will kind of drive home that in the same way our catheter-based treatments of problems in the brain have changed, our open surgery treatment of these problems has also changed. And so what I've done, so what this picture is I've made an incision in someone's eyebrow, taken off a very small piece of bone, and essentially opened the lining around the brain. So what you're looking at here is this is the frontal lobe, and this is a cottonoid that I put in, and we're going to basically go down in there and essentially try to work around the brain to get where we need to go. So what you're going to see first is you're going to actually see me opening something called the arachnoid, because it kind of looks like a spider web. This is the underside of the frontal lobe. This is the olfactory nerve that's responsible for your smell. And I'm going to drain a bunch of fluid down here, your spinal fluid, in order to actually have the brain fall out of my way so I can get to the base of the brain. This is the optic nerve that's responsible for vision. This is where the carotid comes into the head. And now I'm going to try to find where that carotid artery gives rise to another artery, where the aneurysm is. So I'm going to pause this here just so I can show you guys, so you know essentially what you're looking at. So if I pause this for a second, or start the video over, sorry about that, that's my fault. We'll get that going in a second here. I'll just do it from here. I'll get it back to the same part. Okay, so if I just pause this here. So what you guys are looking at here is essentially, this is something called the anterior cerebral artery on one side. This is the anterior cerebral artery on the other side, and they're joined by a small artery called the anterior communicating artery. These arteries form an H and are responsible for blood flow to the parts of the brain that move your legs. This is the aneurysm sitting right here that's bled. And so what you're going to see, I'm looking down very deep in the brain through a microscope, is we're then going to inject dye, and we're going to see this aneurysm filling with blood. I'm then going to actually put a clip on in an effort to close off the aneurysm, but not close off any of these arteries. And the hope is then that would protect the patient from bleeding again, and obviously prevent them from having a stroke by an interruption to part of the brain. So that's what you guys are looking at now. And so I'm now just trying to make that room. And you're going to see the dye injection here very, very soon through the microscope. And I can't get any of these little arteries in. So this is the injection through the microscope. So you see the aneurysm here. You see this artery and that artery, and this is the H. So now I'm going to come in with a clip and try to clip that aneurysm. I'm looking behind this to make sure I'm not going to catch any small arteries that provide blood flow to the deeper parts of the brain. And this is just coming in with the clip through a very deep hole in the brain. Opening in the brain. And you see I'm gently putting that one side in, then I have to rotate my hand and slowly let the clip down. So that's what we're doing. And this is much more difficult to do than when you do these aneurysms through a conventional opening, through a much larger craniotomy, because I can't rotate my hand that much. That's why it seems like, I'm shaking a lot, but I'm really not. That's like very, very deep, very far away. And so you can see here, this artery's open, and there's no filling of the aneurysm. So that's what aneurysm surgery looks like in the brain, and that's just showing you, that's the top of the clip, how far into the head we were. And so now, I'm going to skip ahead because you guys are interested in surgery videos. I'm sure they're a little bit better than looking at these images, and we have such little time. This is just an example of a woman who had had really, really bad jaw pain, and this aneurysm was pushing on the nerves that are responsible for feeling in her jaw and mouth. So she'd gone to a dentist and had a bunch of teeth taken out, but it turns out that this was her actual problem. So this is after I've opened the lining around the brain. This is the brain stem, the connection between the brain and the body. These are the nerves that are responsible for hearing and movement of the face, and this nerve that's responsible for movement of the jaw is being crushed by this aneurysm. So what I did is I then clipped the aneurysm, and after clipping the aneurysm, moved this artery out of the way and decompressed these nerves. And of course, in doing that, we cured her aneurysm and her jaw got much better. Similarly, when we take out vascular lesions deep in the brain, each person's functional anatomy varies quite a bit. And so we now actually combine MRI imaging with the use of EEG. So I actually know which part of your brain moves your hand in you as opposed to in the average person. And based on that, I can plan a trajectory to take out a lesion that's bled in the brain. So this was a young guy who was skateboarding and he fell and he had a seizure and he had this lesion called a calamoma that had bled into the brain. And so then I used this imaging to actually go in and take that lesion out for him. Similarly, this is a guy who basically had a blockage of the arteries in his legs from IV drug use. And if you guys use drugs, you should stop. It's not good for you. And if you don't start. A couple aneurysms here. Was able to actually treat those for him, both with open surgery and the use of catheters. That's just an example of that, and that's him afterwards, and he doesn't use drugs anymore, which is good. I'll skip ahead to one other video that I think is helpful for you guys to see, because I think many people smoke cigarettes or eat things that they shouldn't, and you can hear that your arteries can get blocked in either your neck or your heart because of that. But I think that people don't have a really good sense of what's living in their blood vessels, and so I think this video will actually show that to you if you're interested in seeing it. There was a patient who actually had a stroke. This is just some other stuff. This is, if we had a little more time, I could teach you a lot about blood vessels in the brain. But this is a patient who had a stroke because of the blockage of the carotid artery in their neck, and I can just show you a very quick video of what taking out that plaque looks like. So this is actually after opening the neck, and this is the carotid artery. This is the external carotid artery that provides blood flow to the face, the common carotid artery, and the internal carotid artery. And I won't show you the whole video just because we have such little time, but I'll show you what's living in your arteries. So what we're going to do is we're going to clamp all these arteries, and we're going to actually open that artery up. So there's a clamp on the internal carotid artery, then a clamp on the common, then a clamp on the external. And then we're going to actually open this up. Is everyone okay seeing this? It's not going to make no one's going to pass out. Everyone's okay? Okay. I should have asked that before, sorry. Then we'll open this up. You'll see just a little bit of blood that's trapped in there, but then that'll go away. This is my chief resident. Open this up. So you see they're a little shaky, but that's okay. And so we're going to open all that up, and then they're going to, so you can see this kind of gross yellow stuff that's living in your arteries. And then if you do this operation correctly, after you actually cut into this, you actually try to deliver this whole plaque out in one piece, kind of like delivering a baby, which is also cool. One of the best things about going into medicine, I should tell you, is that it's really the chance to help people a bunch of different ways. And so you'll have a chance to develop a whole series of skills that will put you in a position to help others, which never gets old. So this is what's living in your arteries. Pretty disgusting, right? So it makes you want to eat a little healthier. And then you basically just sew that up. You wash it out, sew it up. And that procedure is called a carotid endarterectomy. And that's what your arteries looking like at the end, all sewed up, looking good. So I have a bunch more stuff I could show you, but we have very little time. And so I'd like to open it up to any questions you guys may have. Yeah, please.
So we've heard from a lot of people, that intervention radiologists and multiple other people, talking about how the procedures, the future procedures are going through catheters and going through the blood vessels. But in neurosurgery, there's a lot of things you can't necessarily get with catheters, with tumors and such. What's the future of non-catheter based operations regarding cranial.
Yeah, it's a great question. So here, I'm someone who does both. So I direct the neurointerventional program at UCSD, and I also do open surgery. And in my view, I think that's what the future is. I think that disease doesn't really respect subspecialty lines, and so you always want to make sure you have all the tools available to you to treat a given problem. I think it's also important that if you're offering someone a procedure, that you can manage all the downstream complications of that procedure. So if you do a peripheral radiology procedure and you get into trouble and you cause a bleed or you cause an injury to that artery, you're going to have to call a surgeon to come help you. Whereas if you are a surgeon who also does catheter-based procedures, if God forbid you're in a situation where you cause a bleed in the brain or a problem, I'm the person who would actually go take that blood clot out or put a tube in to lower the pressure in the head. So I think that we're moving towards a time where in most fields where surgeons control the patients, you're going to see that the surgeons who actually have catheter-based skills are in a stronger position than people who train in a purely procedural-based specialty like interventional radiology. I can tell you that my fellow now is a radiologist by training, and I think that those people are always going to have to practice in environments where there are surgeons available to back them up. In the same way that our technologies and the treatment of catheters is changing, our surgical techniques are also changing quite a bit. As I mentioned, the surgery I just showed you used to be done through a very large opening and kind of like a trapezoid. It would narrow down to your point of action. And we've been able to invert that trapezoid through very small keyhole craniotomies because we have much better microscopes now. We can actually see very far down through very small holes. We also use endoscopes for surgery in the fluid spaces of the brain, and our navigation and our imaging are also much better. So I think there's going to continue to be a role for surgery in those situations. So I don't think, so the short answer is I don't think surgery is going away. I think the opposite is true. I think technology is actually going to put us in a better position to offer surgical solutions to problems we couldn't solve with surgery before. Yeah, please.
I'm just curious, the girl who had like the tennis balls.
Yeah.
Can she see now, or?
Yeah, so she's 20/30 in both her eyes. She's like back to driving. She's actually not a girl. She's like a 65-year-old woman. But you know, she's like back to golfing and doing all that stuff. And so yeah, so she's really happy that way. Yeah, please. Oh, I'm sorry. Over here.
How do advancements in neuroscience affect the field of neurosurgery?
The short answer is a lot, because I think that ultimately neurosurgery is the point of action for all medical science advancements. And so when you think about neurorestorative therapies, like stem cells, ultimately the vector by which those stem cells are going to be delivered is through a surgical procedure. When we talk about the treatment of tumors, that's always going to be, the surgeon's always going to be the person who's in the center of that issue, because they're going to actually be the one offering you the biopsy, resecting the tumor, drawing the planning for the radiation that comes after that in conjunction with a radiation oncologist. And so I think that most of the advancements you see in neurosciences more broadly are ultimately just going to expand the diseases that are treated by neurosurgeons. Like the things that I'm showing you now, and we didn't get a chance to really go into it, it used to be, for example, if you had a blockage of one of the arteries in your brain, there was nothing you could do. You just had a massive stroke and you either died or were permanently disabled. And now I can show you a ton of videos of patients who come in where I've used catheters to open that artery in their brain and restore blood flow to the brain and interrupt that stroke. And people have made very, very dramatic recoveries. And so I think those kind of advancements are going to continue. Other medically treated diseases that now we're making huge advancements are like Parkinson's and epilepsy. So the use of stimulator technologies deep in the brain are really interrupting seizures or recording seizures before they happen. We're also interrupting a lot of the positive symptoms, for example, in Parkinson's disease, where you actually have an essential tremor. We now, with deep brain stimulators, can make those tremors go away. And so diseases that used to be treated kind of uniquely with medications, we're now actually finding a structural cause and are able to chase that a little bit more surgically. Yeah, please.
Neurosurgeons, they have to wear the lead thing, right?
So when you're doing procedures involving x-ray, then you have to wear lead. But for example, the craniotomies that I showed you, I'm not wearing lead in those cases. I'm only wearing, how heavy is it? It varies. You could wear lead. That's what you're asking. Yeah, it's under 10 pounds. They vary in thickness. Some are heavier, but some are a little bit lighter.
You have to work out.
How close is like the real hospital experience to like Grey's Anatomy?
Oh, that's a great question. I think it probably depends on your social status. Single, no, I'm just kidding. No, I think that during residency it's maybe a little bit closer to that, but I wouldn't say it's quite as exciting as people like switching boyfriends and girlfriends every 5 seconds. It's not quite like that. And I wouldn't say the medicine is very close.
Like the situational.
But the situation in terms of like, there's probably fewer places in the world where there's more human drama than in a hospital, only because you're really, as a doctor, privileged to be invited into the moments that define people's lives. You're often meeting someone who's a neurosurgeon on the worst day of their life because something's just happened to them or one of their family members. And you have about 30 seconds to really inspire confidence that you're the person who's going to manage that and through that. So it's a real privilege and again, an opportunity. Yeah, please.
What classes and majors do you suggest like in college that we should take if we want?
Yeah, no, I appreciate that question. So, I think what's really important is there's this kind of culture when you're as someone who's been on medical school admissions and college admissions. I can tell you that people think they got to do X, Y, and Z to check a box in order to get to that next step. And I'll tell you that somebody's evaluating a lot of people in that position. It's really obvious when someone's actually done that versus when they're passionate about something. So I majored in industrial engineering and economics in college. And the reason that I did that is because I kind of viewed each stage of my training as my last chance to do everything else before kind of further. And so I do think it's really important that if you're really passionate about biology or chemistry or math and you want to do research to move forward, that you do that. But I don't want you to feel like you need to do that in order to go to medical school. If you do the requirements and want to major in something else, you're not going to get a chance to study again, like music or philosophy or economics. You definitely should do that. Yeah, please.
What are some factors that initiate the creation of tumors? And aneurysms?
So aneurysms, definitely. So modifiable risk factors are things like smoking, drug use, or really uncontrolled high blood pressure or diabetes. Things that you can't really control, there are definitely familial syndromes that predispose you to multiple aneurysms. That's a big factor. And obviously there's certain other developmental syndromes like Down syndrome that can predispose you to aneurysms. But because they're relatively rare, there are about 30,000 ruptured aneurysms a year in the United States. We don't know completely, and it seems like one of the more unfair things that happen to people. Because the common question I get is, why did this happen to me? And the truth is, we don't know.
What's your weekly schedule like?
So it varies. I tend to do catheter-based procedures on Mondays and Tuesdays. On Wednesdays I do surgery and operations. And then on Thursdays I see patients at night and Fridays.
I'm a big fan.